Thanks my old friend, Professor Zakaria, for his invitation. How high-resolution endoscopy with artificial intelligence will change our practice? It's a new clinical concept developed since a couple of years. It will change definitely how we do clinical endoscopy. What could you expect from AI in digestive endoscopy? Decision assist or execution assist? First, it will be a guidance, like a scope guide for colonoscopy insertion. Diagnosis, computer assist diagnosis for cancer staging. CID for normal mucosa or inflammation, important in Crohn's disease or ulcerative colitis. Enhanced blood vessel, disease prediction from patient data. And for treatment, it will be important to delineation of a lesion, especially for early gastric cancer, rebleeding risk assessment, or semi or full automatic treatment. For guidance of colonoscope, this is a prototype from Olympus. There are 2 points. First point, with the arrow, the prototype gives you the possibility of the opening of lumen, and if you push too hard on sigmoid loop, sounds attract your attention. Be careful, you could involve perforation. Of course, we have a lot of legal issue before this prototype could be launched in practice. The first step in clinical practice is polyp detection. But for AI, the important step is learning from data. So we need a lot of picture, we need a lot of video. So the performance of the system will depend on the training data and validation study, from predictive algorithm data to output. On this slide from Hassan. This paper from Vru, published in Endoscopy last year, show the importance of AI for endoscopic detection of early gastric cancer without blind spot. As you know, more than 3,000 gastric cancer and nearly 6,000 benign images had been selected, with 25,000 images of different parts of the stomach. And they make a green for detection of blind pot unprocessed with unprocessed video. So the results are very impressive. Non-malignant accuracy detection of 92%, sensitivity 94%, and negative predictive value on 91%. And we monitor blind spots. This is a first clinical important paper on gastric cancer. Same result on adenoma rate detection. 484 patients had been involved for colonoscopy with or without CDE. All results are very impressive on polyp detection rate, adenoma detection rate, per patient number of polyp, per patient number of adenoma, and increase of number of diminutive adenoma as an increase of number of plastic polyp. This slide from Cesar Hassan is very important on clinical practice, with the concept of neoplasia, non-neoplasia, true positive, false negative, true negative. And the question, does the endoscopic reject the true positive? Does the endoscopic detect the false negative? Does the endoscopist accept the false positive as a true positive? And does the endoscopist confirm is a true negative? This is all this concept should be now assessed of a various AI tool. This is a study design where the practitioner carried on the colonoscopy without AI, and the assistant is able to detect false negative, false positive on the different screen with AI. For the scoring system, we could define 4 different situations. First, obviously false positive. The system gave obviously false detection due to stool, air, bumble. Second is over positive. After its location disappeared from the image, the endoscopist is had to return. If they find there is a polyp, there's an additional detection. False negative, the endoscopist found a polyp, but the system missed it. And true positive, the system and the endoscopist found the polyp. This is another study published by RIPC in gastroenterology. We have 2 groups of patients, one group with AI and one group with standard colonoscopy. We exclude patients with poor preps, so the evaluation on 341 patients and 344 patients show clearly the adenoma rate detection, and the adenoma per colonoscopy is more important on the AI group. The overall result show the importance of AI on detection rate, polyp size, polyp morphology, and colon location. But this study has some limitation because they are carried with an expert, a low detector positive. They have no difference in clean withdrawal time, no increase in unnecessary resection. So AI is a benefit, but still we are on the preliminary stage. On this meta-analysis, Cesar Hassan show the importance of sensitivity at high level, whatever you use, Medtronic, Pentas, Fuji, Burnett, but also we have to draw the attention of false positive, because if false positive are too high, the attention of the operator is lower and it gets boring. Optical biopsy in colonoscopy, it's another AI supposed to be benefits. The goal is to reduce costs of unnecessary polypectomy, assessment of diminutive polyp, optical diagnosis based on image-enhanced endoscopy. It's now an alternative to histopathology confirmed by ESEHG. The performance result, more than 90% negative predictive value for identifying diminutive rectoscopal polyp with hyperplastic polyp, and the result of CAD is standard diagnosis, audit of all endoscopies, and reduce of healthcare cost. The concept of optical diagnosis had been developed for more than 10 years with a nice classification, GNet classification, able to differentiate type 1, type 2A, type 2B, and type 3. But in clinical practice, except in expert center, this NBI scale, such also LBI scale from Fuji, are not clinically used on daily routine, and we could expect AI will be able to give the right answer to the colonoscopist. Oh, il dort. As you see on this slide, for neoplastic lesion, machine is more reliable than colonoscopies with a high confidence and probability reach 99%. In this slide, using image enhanced endoscopy with high resolution scope and near focus, the diagnosis of NICE 1 hyperplastic polyp reached 100%. That is more that we achieve in clinical practice with non-expert endoscopists. AI will improve also therapeutic endoscopy. As you know, early gastric cancer, it's an important point for diagnosis and treatment, especially in Asia. Delineation of the lesion is very crucial before doing ESD or MR, and we could expect the AI analysis will give the right delineation for the endoscopist and not, as we are doing by the time being, just some point with a surgical instrument around the supposed to be limit of the lesion. On this slide, published by Kanazawa in GI Endoscopy in 2018, you see on the bottom of the upper part, A and B, the clinical evaluation of the early gastric cancer and delineation by an expert. On this original image, the computer make histogram equalization, then they show clearly the limit of the lesion and give a partition in a block in order to have a very clear and easy to understand it. No. On this paper published in GI Endoscopy in 2018, the upper part, A and B, show the delineation with NBI magnification made by the expert. On the middle part, this image is learned by the computer, and they make histogram equalization, then Gaussian filtering, in order to make partition in block, making it easier the delineation of the lesion for the endoscopist. Here is two examples of AI on delineation on early gastric cancer. On the upper part, you could see on A the NBI with magnification by expert examination. Microvessels are irregular or disappear. The mucosal pattern is destructed. On B, you see the same picture with AI application in order to have a better delineation before ESD. And on C, on red, is the AI detection of microvessel with accuracy more than 72%. On bottom part, it's exactly the same kind of studies. On A, the usual colonoscopic aspect with the NBI, magnification, vessels are irregular, distorted, enhanced. The mucosal patterns are irregular or disappear. And on B, you see the application of AI with more accurate delineation, and on C, the detection by the computer of the vessel. On this slide from the Shenyo-Kudo group, we show the last application of AI. AI may help in predicting the need for additional surgery after endoscopic resection of T1 colorectal cancer. It's important in that case to predict number of lymph node metastases. Kudo recruit 690 patients over 15 years, 590 for machine learning, 10 for validation. And the results are very impressive. Unnecessary further surgery specificity 77% for AI versus 85% using various guidelines from state, Europe, or Japanese. That means, in that case, the AI avoid unnecessary further surgery. When we talk about AI in digestive endoscopy, we should state more accurately computer head endoscopy. As on live video and picture, a lot of features are depending of the operator: bowel preparation, handling of colonoscope, rate of cecal intubation. They are directly linked with the human expertise. And also, false positives are a drawback. If there are too many, they reduce operator attention. But the overall computer head endoscopy is important for detection characterization. And there are one exception, it's the capsule. In that field, the computer do everything without human intervention. Here is a real-time colonoscopy with, on the left, the green square show definitive polyp abnormality, but on the right, it's a false positive, which is a drawback of the system. In capsule endoscopy, every diagnosis are carried on by the computer. This is a study from China where they include nearly 7,000 of patients in 77 centers. The number of abnormal and normal images are enormous, and they're able to characterize not only the detection, but accurate diagnosis for normal, inflammation, vascular, polyp, and so on. And validation with 5,000 patients. And the overall result, accurate diagnosis by the computer is 6 minutes. Accurate diagnosis by expert endoscopists is 27 minutes, but show clearly the benefits of AI in capsule endoscopy. And finally, computer head diagnosis raises a question of responsibility. for cancer interval, who is in charge, who is responsible, the physician, the software company. We know colonoscopy quality is a multi-factor. Boston cleaning assessment had been recorded, cecal intubation documented, 6-minute withdrawal, and the tool of a new computer had about false positive rate, false negative rate, overall assessment, and the legal issue are also variable from one country to another country. And finally, in case of missing polyp or missing cancer, should we blame colleagues not using computer with head endoscopy software? Still, we have a lot of issues to solve before the computer and endoscopy will be in clinical practice in all countries. In conclusion, artificial intelligence is a major step in capsule endoscopy. Computer-aided diagnosis is a major improvement. Software should be approved by the scientific community. Computer-aided will improve overall endoscopy quality and digestive healthcare. And finally, the future of digestive endoscopy is bright in the hand of the physician or surgeon endoscopist. Thank you for your attention.
Perfect, we get it.
Thank you very much, Professor Jean. Actually, just a question regarding the AI and bowel preparation you mentioned. In what aspect?
Sorry?
You said that AI can help in bowel preparation or something like that.
Because, no, AI should assess, because, you know, what we expect by the time being, first is AI help for detection. But, you know, for quality endoscopy, in the future, AI and the report from AI should assess not only the detection, but the quality of endoscopy. Is the bowel properly clean? Is the physician able to read the cecum? Is the physician make a very minute withdrawal? It's not only detection, it's the overall quality of endoscopy, what we could expect in the near future.
The point of the false positive results. So what's your comment here?
I try a couple of equipment, but I think they are not fully adequate. I know we have two papers published last month. They say false positive, it's just 2 or 3%, but by using technically myself in clinical practice and ask my colleague to use it, when you have too many false positive, you know, your attention dropped. And I think it's really a crucial point. We should have when it will be very commercially available system, we should have a system with a very low false positive, because if you have too many false positive, you are disturbed.
Finally, the AI and the quality of the endoscopy. You said it is used with the NPI and others. Any further new generations of endoscopy with AI or?
You know, the new generation AI, they're coming let's say every month. A lot of companies are working, but very few are used clinical trial. And I think for our new colleague, young colleague, AI will be very positive, but the question mark by the time being, especially because AI will be costly, what could we give to the patient? What can we tell to the patient if our colleague or hospital are not able to provide AI? That is really an important question.
Thank you very much. Any other questions, please, from the floor? Okay. Thank you very much, Professor Jean. Professor Helmy, you want to introduce the next?
No, I have just, I like to say that I enjoyed very much this session, and this endoscopic procedures is very interesting and marvelous. Thank you, all of you, for that session.
Okay.
And thanks to Professor Serag and all of you. Thank you, Dr. Abbas.
Thank you very much. Now, Professor Serag.
Great. What do you think? You resume to us the introduction of spiral endoscopy, because it seems that it is difficult to make the lecture now.
Okay, I will just give you
please
5-10 minute comment about spiral endoscopy. We would slide, old-fashioned, very old-fashioned, just speaking.
I know now why you were president.
Exactly. So it's a pleasure. Concerning spiral endoscopy, I think it's a breakthrough. We are working for 20 years with a double balloon, for 15 years with a single balloon. In the past, I used to work with a manual spiral, and I really enjoy the manual spiral. So I tell to Olympus, you have to do something like that. And they bought the patent from Ackermann, and they developed the motorized spiral. What you have to understand, motorized spiral is special scope. It's a special scope with a motor built inside of the scope, and we have an additional part, a distal part, with a screw. The spiral is really a screw, but the difference with Ackermann is just a special scope with a motor, and you have a distal part you have to insert. It's a disposable. This has been developed by first Hosny, and now we use this spiral for nearly 1 year. We have two questions for the spiral's use. First of all, most of the colleagues are using general intubation, general anesthesia with intubation. Personally, I use only propofol intubation, like ERCP, propofol sedation, like ERCP. You have to avoid patients with varices, because the screw could damage the varices and acute bleeding. And you have to have a anesthesiologist to give you good sedation, because the equipment is quite large. So you have the tricky part. One part is when the patient swallows the scope. You are really to have a patient very, very sedated in order to screw step by step the equipment, and avoid to block the equipment on the esophagus. And the second part, what's a little bit difficult, is the duodenal jejunal junction. We have the trax angle is very tight, so you have to pass your equipment very slowly, and sometimes you have to pass to withdraw, to push and screw to pass slowly. But when you are used to the two trick, then you are in first part of the jejunum, and just you screw your equipment and your small bowel on the equipment. It's very to use and very fast. So in 10 minutes, you are in a deeper part of the ileum. Second point, when you unscrew, you have to be step by step, and it's easy to keep the lumen very steady if you have to use APC, clip, and so on. And the last point, the sedation should be very deep until we have totally withdraw, because again, the esophagus is a slight difficulty. If I look about, what we have done in my unit, for 1 year, we have done 50 patients, and we have just 3 patients we are not able to complete the examination for technical problem, sedation or difficulty to pass the duodenal jejunal junction. So the 27 patients required treatment, and the treatment was much easier. And one point about this equipment, we have a large channel, so it's easy for therapeutic endoscopy. Second, we have a water jet, and it's really important to clean when you have a bleeding. So in summary, I think it's a new equipment, but the only drawback is need expert. By the time being, Olympus restrict the possibility to use this equipment only on expert center, because if you are not able to pass very, very smoothly on the esophagus, if you are not how to use in the small bowel, there could be a damage. The number of, by the time being, the number of reports are advisory events are minimal, free, not in our visit, but they are free in Europe. And last point, this equipment could be, I may say, could be used in ERCP after Bill wrote and so on, but by the time being, it's really early possibility to use equipment. I hope this equipment will be more available, but I give you an advice, a warning. If you use this, you should have good training, excellent training.
Thank you very much, Professor Jean.
Next time you will have a slide.
Yeah.
Very clear message, to the point.
Yeah.
Thank you very much, Jean-Francois. We thank all Chinese friends for being with us since 9 o'clock. Dr. Zhou and Dr. Wang and the colleagues, and the marvelous colleagues and the doctors, endoscopists, and the marvelous secretary, Miss Lan, who is the woman behind this activity with us. We thank you all, and the presence of Jean-Francois Ray always enrich any meeting. See you tomorrow, Professor Ray, at 5 o'clock for a very interesting subject again. Okay, thank you very much, and we'll move to the next session. Thank you. Bye-bye.
Thank you. Thank you. See you tomorrow. Oh, le con.